Thank you. Ms. Capps.
Thank you, Mr. Chairman, and thank you to these witnesses and for your perseverance and staying as long as you have. I want to divide my time and turn first to Dr. Gawande and then Mr. Ebler for the last half of my precious 5 minutes. Dr. Gawande, I appreciated your testimony very much, as I told you, and I'm very interested to learn more about your idea for a National Institute for Healthcare Delivery. As we develop a strategy to improve our health system overall in that big picture, clearly clinicians are the most integral players. And I would like to ask how you foresee a National Institute for Healthcare Delivery or something like that working, and how we could get that information to clinicians, how actually you would see that implemented.
So a good example would be to break down our services that we provide into several buckets. We do 3.5 billion prescriptions. We do about a billion office visits. We do 120 million ER visits. And if you had a National Institute of Healthcare Delivery, they would focus on asking, why do the ERs not work? What are the tools they need to get rid of diversion, to deal with organizational problems, to stop the waiting times in ERs, to divert the group who are getting non-urgent care but should be in other places? They would invest in programs that we don't invest in, for example, experiments with how do you triage people correctly so they go to the right place safely and get quality care and save money. NIH does not pay for that work. I spent 3 years trying to say that we know how to make surgery have fewer complications, but there was no funding in the government to get it. I got the funding to carry out an American study from the World Health Organization. In the end, it only took about $100,000. I made sure we tested it in 8 countries, and I showed here at home that we could reduce our complications with a 90-second checklist that costs nothing at all. And so that's the kind of work I can imagine coming from a National Institutes for Healthcare Delivery, service by service in the ER, in dialysis, in operating rooms, and in offices and clinics. What is it we need to make those places organize all of these drugs and technologies we're trying to deliver?
Thank you very much. I think we need to follow up, or at least I would like to follow up with that. Mr. Ebler, some of the testimony that's come forward today during this hearing argues that we should look at private arrangements, well, that sort of sacred physician-patient relationship in the private context. Or others have argued that our healthcare problems can be solved through a tax code alone. In other words, leave those decisions in that other sector. Your research seems to indicate another direction, and maybe you would elaborate on why this might not work according to some studies that you have access to.
Let me say what we found, and it's not, we're not speaking particularly to different options that the subcommittee and committee have for reforming system.
Right.
Our message and our research really hones in on the fact that people who have no coverage are getting less than they need. They're suffering worse outcomes, and that it relates a little bit to Mr. Deal's question. Very good research that when you add coverage, whether that be children becoming eligible for CHIP or adults becoming eligible for Medicare, for folks who are previously uninsured, you see very positive results of that. So that is the way to go. So the message we have for you is the need to proceed, the need to make sure that those uninsured patients get coverage so that they can have a connection with a physician. The flavor of that approach of the different options in front of you, we don't have a view on that at this point.
Your basic discovery, if you will, it sort of makes sense too, that if you don't have a regular path to some provider that you use for small things, that then when you are forced because of the drastic nature of your symptoms to seek health care, you're not going to have as good an outcome. And you have documentation to show that's true. So which kind of care it is that we pursue with some kind of goal of everybody getting coverage some way, is it less important to you than the difference between not having coverage and having coverage?
Correct.
Or access to non-access. Anyone else? I have 16 seconds left. If anyone has a final thought on that topic. I appreciate that very much. I think it gives us a good starting basis from which to, I hope we can all agree, as a result of this day that we spent with you, that it's more important to have some access to care than not to have any, even though there is care available in the community.
That's an important point, because these studies, the simple reality is the uninsured are getting some care.
Sure.
And there's a safety net out there. There's doctors and nurses and hospitals trying to help every day. But the simple reality is when you adjust for all the things you need to adjust for, they're not getting the clinically appropriate care and they're suffering worse outcomes.
I yield back. Thank you very much.
Thank you, Mr. Ging.